We are going live in 5, 4, 3, 2, 1. We are live.
Good evening, everyone. Good evening, everyone. We welcome you all to Ortho TV in association with Emcure Pharmaceuticals on this World Osteoporosis Day special. To introduce today's topic and the speaker, I hand over to Mr. Ketan Kulkarni from Emcure.
Thank you, sir. And a very good evening to everyone. I'm Dr. Ketan Kulkarni from the Medical Services team at Emcure Pharmaceuticals Limited, based in Pune. On behalf of the entire team at Emcure, I welcome you all for this webinar. So osteoporosis is a systemic skeletal disease, and it is characterized by low bone mass and a microarchitectural deterioration, and with a consequent increase in bone fragility and susceptibility to fracture. So more than 61 million Indians have osteoporosis, and as compared to the Western counterparts, the osteoporotic fractures in the Indian population, they occur around 10 to 12 years earlier. And more than 4.5 million women above the age of 60 years in India have a fractured spine. And more than 250,000 people in India sustain a hip fracture every year. So I wish you everyone a happy World Osteoporosis Day 2022 to all of you, and also those who are attending today's important webinar. So to give you a history, the World Osteoporosis Day was introduced in 1996 by the National Osteoporosis Society of United Kingdom. This campaign was supported by the European Commission also. And then the World Health Organization came forward to help the IOF to spread the information and awareness of this disease. So today we have a very distinguished and eminent faculty from across the 4 zones of India for this webinar, and we have an exciting agenda for the next 1 hour. So I thank all the faculty for accepting today's invite, and also to enlighten the audience on osteoporosis. So we have eminent faculty today: Dr. Chadda sir, Dr. C. Rex, Dr. Prani sir, Dr. Sandeep Garg, and Dr. Indranil Dutta sir. So now I will introduce the faculty for today. We are blessed to have with us Dr. Chadda sir, who is joining us from Mumbai. He is a Vice President, Indian Orthopaedic Association. He is currently working as a consultant orthopedic spine surgeon at Lilavati, Jaslok, and Global Hospitals, Mumbai. He has 30 years of rich experience in the field of spine surgery, and he has pioneered the minimally invasive cosmetic spine surgery in India. Sir has numerous scientific papers, editorials, podium presentations in national and international conferences. He has been served as the Foreign Fellowship Committee and was the chairman of the Center-State Relationship Committee of the Indian Orthopaedic Association, past president of the Association Spine Surgeons of India, Bombay Orthopaedic Society, Bombay Spine Society, chief national delegate, Asia Pacific Society, council member, Asia Pacific Orthopaedic Association, and he has recently pioneered the robotic spine surgery at Navi Mumbai. So I welcome Dr. Chadda sir. Sir, welcome to this webinar. I now introduce Dr. C. Rex, who is joining us from Coimbatore. He is the Chief Consultant Orthopedic and Trauma Surgeon and Head of Department of Orthopedics at Rex Ortho Hospital in Coimbatore. He was appointed the Northwest Regional Health Authority as a visiting specialist registrar in orthopedics from 1st August to 31st July in Manchester, UK. He has given numerous presentations and guest lectures in national and international orthopedic conferences. He has 25 publications in index journals, 2 chapters in books. And also he has been conferred the Best Doctor Award for the field of orthopedic surgery by the Emcure University, Chennai. And also he has received IOSUK Senior Fellowship Award in 2013. And he has received the Xavier's Gold Medal for the Best Hand Surgery paper awarded by the Tamil Nadu Orthopaedic Association in 2013. I also welcome now a senior orthopedic surgeon from Lucknow, Dr. Sandeep Garg. He has established the 100-bedded state-of-art trauma center and super specialty tertiary care hospital in Lucknow. He has a vast experience in the field of trauma and joint replacement surgery. Previously, he has worked in the Vivekananda Polyclinic and Institute of Medical Sciences, Lucknow, a senior consultant orthopedic surgeon for the past 15 years. He has organized numerous orthopedic surgery workshops and has many publications, presentations in national and international conferences. Welcome, sir. I also now welcome Dr. Indranil Dutta, who is joining us from Kolkata. Sir is a senior consultant orthopedic surgeon. He has done special training and fellowships like fellowship in arthroscopy from KIMS Hyderabad, advanced certificate in hip surgery from Delhi, Elizarov fellowship from the Russian Elizarov Center. He has been attached to the Sevayan Nursing Home in New Alipur, Kolkata, and his special areas of interest include trauma, arthroscopy, and Elizarov surgery. Welcome, sir. Also, I now welcome Dr. B.K. Prani, sir, who is joining us from Miraj, Maharashtra. And sir is a consultant orthopedic surgeon at Accident Orthopedic Hospital and Joint Replacement Center at Miraj. And also, sir is the visiting consultant in orthopedic oncology at Sri Siddhivinayak Ganpati Cancer Hospital in Miraj. He is the faculty, Ripoy Academy, also primary orthoplastic course and cadaveric workshop training. He has also done special training and fellowships, minimum in incision surgery, revision arthroplasty. Special interest of his include the hip, knee and hip arthroplasty, and he has done on different research work in different bearings, designs, ceramic and oxynium implants. The flow of the program is after my introduction, Dr. Ram Chaddha sir will speak on osteoporosis overview and treatment options in 2022. And Dr. Rex sir will moderate the panel discussion on current landscape in the diagnosis and management approaches for osteoporosis, followed by a short overview on the website www.osteoporosis.com. So, having said this, I thank all the faculty for joining in today. And now I hand over the session to Dr. Ram Chaddha sir to enlighten on the topic. Over to you, sir.
Thank you very much, Dr. Ketan Kulkarni. On behalf of the entire faculty, we are most grateful to you and to your organization, Emcure, for having got us together on Osteoporosis Day. Osteoporosis is something which has affected and will affect humanity forever. And unfortunately, what happens is that rather than add life to years, we are adding only years to life. And the probable reason is osteoporosis, lack of information, and even lack of medication or advice handed over to people who are suffering. I share with you what I've learned over the past few decades. I sit in the room besides my mother, who is seated in the next room and who's turning 100 in the next few months. And she's 40 years older than I am. And I believe that if she has good quality of life, she needs her friends around her. And days like this encourage us to add quality of life to the elderly. We all believe that we have strong bones in the youth, but as we age, they become brittle. We end up with fractures, become invalid, and are incapacitated for life at times. One fracture in the elderly can be life-changing, life-threatening if it's in the hip. Hence, we have to know what's really happening. 1 out of every 3 women after the age of 50 and 1 out of every 5 men will have an osteoporotic fracture. There is 1 fracture every 3 seconds. And we have realized and found that between 1990 and if we extrapolate it to 2050, hip fractures are going to increase dramatically. Men have increased by 310% and women by 240% as regards hip fractures. Out of every 3 vertebral fractures, only 1 reached the attention of a spine specialist or an orthopedic surgeon. Hence, 2 remain undiagnosed, and 80% have had more than 1 fracture which was not diagnosed in the past. We have data of 2019 where low bone mineral density related fractures have been evaluated. And if you look at that circle star right in the center, the red lit zone, the orange to red, India is staring at us, where the total number of deaths related to these low bone mineral density fractures are the highest. Yes, Asia is predominant, and India is standing out above all the others. Well, the health burden is equally bad, and disabilities and death both coexist. And that is something where we are adjusting our life to live with this disability. And our patients and the caregivers, the families, are under tremendous burden because of this one entity, which affects quality of life. How do we look at osteoporosis? Well, we all ask for a DEXA, and we say if the T-score less than -2.5 in the lumbar spine, femoral neck, proximal fever, or lower third radial forearm, it's osteoporosis. Well, actually, it's not just that simple. We must realize that it's a trivial fall which can cause a frailty or a fragility fracture. And sometimes with T-scores even better than -2.5, but with other predisposing factors, we may have fragility fractures. There are certain entities which can predict, and if we study them and use them, like the FRAC score, life can get a little bit less complicated. How do we go about assessing these? Well, whenever I have people with back pain, and I have a lot of them coming to me, non-specific low back pain, and women around 50 but who have menopaused, well, I ask them for a bone density. I ask them for certain other tests. If I have a fracture, I also do a FRAX. I evaluate their BMD and probably do it every 2 to 3 years, even if they're osteopenic, not yet osteoporotic. And based on their bone density, I plan the next 4, 10, 20, 30 years for them. We must know that osteoporosis has 2 basic compartments, non-modifiable and modifiable. And this I'm talking of primary osteoporosis, which is senile or post-menopause. We'll all age. This is not modifiable. Women will be more affected, non-modifiable. Ethnicity like ours, more affected. Genetically, some people are predisposed. And we must understand that our peak bone mass is around 30, 35. And if you have not adequately had D3 and calcium by that time, we're going to have weak bones. Modifiable, yes, the type of nutrition we provide ourselves or our children, the amount of calcium, vitamin D3, the amount of sunlight we expose ourselves, how much we avoid smoking alcohol, how much we indulge in exercise, and how much by choice or by accident we have to take medication like corticosteroids, seizure medication, thyroid medication, any or all of the above. Having said that, we have to always evaluate a patient when they come to us. So besides a clinical exam, what do I do? Well, I evaluate them, and if I have a past history, I evaluate them compared to that past with whatever investigations I may have. I do a certain set of tests, which include a vitamin D3, B12, a HbA1c, because I believe if you are a diabetic, then you have to have a lower threshold for intent to treat for osteoporosis, a calcium, a serum PTH, a serum creatinine. And if I have the elderly, I also do a serum protein electrophoresis for M-band, BJ proteins, Ben Jones proteins. And I also do a light kappa-lambda chain ratio. All these to rule out sinister causes. Having said that, if we have younger patients, then we have our endocrinologists on board who can help us with things like testosterone levels and other levels that we need to look at, prolactin levels, and find out if there's some other cause for osteoporosis that is beyond the scope of an orthopedic or spine surgeon. We all age. At menopause, a woman may be erect, but after some time, she will start stooping. She will lose height. And if she loses height of 4 centimeters or more, that means she's probably got 2 vertebrae which are collapsed, if not more. So please remember that 40 to 50% of women and 20% of men will have osteoporosis. We have, as I said, 140 million postmenopausal women. Half of them, or more than half of them, are living in rural India. 20% of women will die within a year of hip fracture. And not just true for women, but even men, and men suffer more from the hip fracture. We have to increase the awareness. Only 10 to 15% of our Indian brethren are aware of this disease. DEXA is not very commonly available. It's a simple tool if available. Recommended, you should have 10.6 DEXAs per million. We have only 0.26 DEXAs per million in our country. Indians fare poorly as compared to the other Asians, such as the Japanese and the Koreans, who have DEXAs more easily available and have better quality bone. Well, there are other screening tools, many of which we don't use. Probably some of the gynecologists use, some of the endocrinologists use. But there's one score which I intend to share with you, which is the FRAX score. There's an Indian FRAX also available. Yes, I do know that this is not necessarily done on an Indian population, but it's done on Indians living out of our country in Singapore. But that does not matter. Their ethnicity was Indian. And we have now got an index which is very easy to follow, a calculation tool. You calculate the age, the sex, the weight in kg, the height in centimeters, the previous fracture, if not, parent fracture of the hip, current smoking, glucocorticoids, rheumatoid arthritis, any cause of secondary osteoporosis, alcohol 3 or more units per day, femoral neck BMD, and put all these together, and we can get an idea of the future of this patient and whether they have a chance of getting a fragility fracture. As mentioned earlier, look at the picture, whether there's a worsening of the kyphosis, if they've lost more than 4 centimeters height, if they have repeated falls, sarcopenia may be coexisting with osteoporosis. Look at other diseases if they have had any. Bariatric surgery hits you very hard. And yes, immunosuppressants, anti-seizure medication, anti-epileptics can add to your quality of bone getting suppressed. How do we treat it? Well, we begin with things which are very simple to say, but very difficult to implement. Have an active lifestyle, adequate calcium, vitamin D3, exposure to sunlight between 11 a.m. and 3 p.m., more than half an hour with adequate exposure, perform weight-bearing activities, stop smoking, stop heavy alcohol consumption. Pharmacological, well, you have those which prevent your bone, your bank balance from falling, and those which add to your bank balance. Those which prevent the bank balance from falling are the anti-resorptives, and those which add to your bank balance of bone are the anabolics. Surgical treatments, my friend is going to talk about in the future, and we'll have a lot of discussion. But here, how do we prevent it? Good diet, good calcium, good vitamin D, limit alcohol, do exercise, quit smoking, avoid falls. There's this very confusing or very, very large algorithm, but I'll make it simple for you. If you do have a patient who presents treatment naive, but with severe osteoporosis or with an osteoporotic fracture, fragility fracture, then they are very high risk. Here you have to choose between giving them bisphosphonates or denosumab, which are in the anti-resorptive sort of a group, or the anabolics, where in our country we still have only teriparatide. We don't have much access to abaloparatide or romosozumab. Among bisphosphonates and denosumab, well, bisphosphonates have been there for over 3 decades. We have all the forms. We began with alendronate, then we had risidronate, then we had ibandronate, then we had zoledronic acid, all of which are still available. And we have been using them with our preferences between 1990s and the 2000s. Then came the new kid on the block, the anabolic, the teriparatide. We aggressively used it. And now we have this newest kid on the block, which has come in, the monoclonal antibody, which is denosumab. Each has its pros, cons, ifs, buts, and we shall discuss them as we go further in the panel discussion. So I have put the cat among the pigeons. I have given you an idea that you are dealing with what was once looked as a silent disease, no more silent. We have to look at situation in India, the gravity that we are facing. Is it now unveiling itself and the true color is coming out? Is there anything in India that's specific that's making our osteoporosis worse? What are the negative effects? Are there easier, simpler lab investigations that can help us treat if there is intent to treat? And how really can we make osteoporosis something that is more known, better known at a community level? Just like we say India is the capital of diabetes in the world, well, somewhere we feel we're there with osteoporosis as well. Thank you all for a very, very patient hearing. I hand over for the discussion both to Ketanji and to Dr. Rex. Thank you all. God bless you.
Thank you. Thanks, Ram. Thank you, Ram. You can hear me, Ram?
Absolutely, loud and clear.
Thanks. That was a very wonderful, very clear cut. You told us the present problem, what we are facing, the osteoporosis, and also you enlightened us the gravity of the problem, how to prevent, and what are the ways how we can investigate and how we can treat. Now, what we will do is we'll take one by one. Let us see. I mean, you mentioned that India is India. We have it's in the red zone, and we are having a huge population with osteoporosis, and that too in the rural population really suffers. So that means I can put it this way, because the Western literature, they say anybody after 65 or something like that, 1 out of 2, they'll be osteoporotic. But India always, we are 10 years less, I would say. After 50 years, I think any female probably should consider osteoporotic unless proved otherwise. Is my statement correct, or am I, overestimating? What is your opinion?
No, I think you're absolutely correct.
Yes, Sandeep. Sandeep, what is your opinion on the present prevalence of osteoporosis and how often you see in your practice?
We see it very often, number one. Number two, you're absolutely correct that there is a huge divide between the urban and the rural population. And that perhaps has been brought about by the awareness campaigns which go around. Unfortunately, they target mostly the urban population. And most of our rural population, number one, has no knowledge about osteoporosis, has no scope of prevention. And as far as number of pregnancies are concerned, they definitely have far more pregnancies than in the urban population. So these are some of the very important contributing factors. And vitamin D deficiency, we've seen that despite the fact that we are living in a sun-rich country and our rural population happens to be exposed a lot to the sunlight, because of the presence of pigment in our body, we hardly absorb that. So that also makes a difference.
Yeah. What do you think, Dr. Prani? What is your opinion on what is the prevalence in your practice of the osteoporosis? How often you see, and what about the male osteoporosis? Dr. Prani?
Dr. Bhaskar Prani, you're muted, sir. Please unmute yourself.
Dr. Prani or Dr. Indranil Dutta, you can answer this question. What do you think in your practice, and how often you see in the male osteoporosis?
Male osteoporosis is not that common in my practice.
Okay.
I have almost 80% rural population in my practice and a 20% urban. There is a lot of difference in the presentation in the rural and the problems in the rural and urban population. Urban population, lack of sunlight is a much more bigger problem. And in the rural population, it is the diet which may be responsible for this.
Okay. Yeah, I think nowadays, because of the long lifespan and the with the better medical care, we see a lot of elderly people with fragility fractures. And all the fragility fractures, I'm not sure the orthopedic surgeons really treat osteoporosis, because they address the fragility fracture. And how many of us really take interest to make sure that they don't come back with another fracture within a year or so? So that is that point. Probably we need to give awareness to all our colleagues to make sure that all the patients must be treated who comes with a simple Colles or a proximal humerus fracture or a neck of femur or a trochanter, whatever. As a part of treatment of surgical treatment, the medical management must be part of it. And maybe if you're not thorough in the knowledge of osteoporosis, you can get a geriatricians or some medical team or endocrinologists involved to prevent further fractures, because we know that 20% of the mortality happens in the post-operative period, the first 1 year of life. And that's a big disaster. I would say this is a silent epidemic killer, and which the magnitude of the problem, which we don't understand or we don't realize, or the public is not aware what is osteoporosis? The biggest problem is osteoporosis is a terminology which comes to limelight only in the last few years. And many of the patients, if you talk about osteoporosis, they're not aware of what is osteoporosis. So that is the biggest problem. So I think we need to spread among everyone and energetically propagate and make sure that the message is gone to each and everyone, especially the people elderly in the family. We need to treat them, like our mother, grandmother, everybody must be treated, and we should not wait for the fracture to happen. I think that is very important. Next question.
I would like to add one point here.
Yes.
You very rightly said that we need to prevent osteoporosis and we need to prevent further fractures in patients who have already had fractures. So, and I also take this as an opportunity to target my patients towards getting that osteoporosis treated. Because once a patient, there is a patient who hasn't had a fracture at all, will less likely to accept any osteoporosis or especially an aggressive osteoporosis treatment. On the other hand, if you have a patient who's had a recent fracture and you've treated the fracture, now you tell that patient, okay, now you need to take treatment so that you don't get another fracture in the future. So these people are far more motivated to get an aggressive treatment like that, an injection teriparatide for a period of 2 years or whatever.
Correct, correct.
I have a small input here, Dr. X.
Yes, yes, Ram.
As I look at it, any lady postmenopausal with a fracture of the hip, the spine, the distal end radius, the neck of the humerus, upper end humerus, has to be looked at as a fragility fracture unless proven otherwise. Okay, that's the first thing. Any man above 60 has to be looked at in the same way. And having done that, a mindset among us, which is our brethren, is that that fracture is to be treated like we treat osteoarticular tuberculosis. Now hear me out, listen me, give me a chance. Whenever we do any surgery for osteoarticular tuberculosis, we do the surgery, but we counsel them that our surgery is only taking care of the mechanics. The biology is to be taken care of by medication. And tuberculosis, we have been treating over the years from 9 months to 18 months and 24 months and multi-drug resistant. It's exactly the same mindset. We have to then convince our treatment naive patient that whatever surgery we do is taking care of only the mechanics temporarily. And if you want long-term healing, you need to take medication for minimum of 2 years. Whatever you're giving, whether you're giving bisphosphonate, whether you're giving denosumab, whether you're giving teriparatide, the first slot is minimum 2 years, at the end of which she or he would repeat a DEXA and further medical management would be planned. So I would like to let that message go through that when you look at any fragility fracture, first suspect it, and after you suspect it, look at that patient as a long-term patient of yours, not just fix the fracture and forget it. No, that's not the way it works.
That's very well said, Ram. I mean, it's well quoted that it's like tuberculosis. Yeah, that's the second part is the forgotten entity. That is what I am saying, that medical management, many of us are not involved into, but I think it is very important. It's the right time. We need to address the osteoporosis at the same time when we fix the fracture. That's a very good comparative example. I mean, coming to the factors, what leads on to increased osteoporosis in Indian population? I think there are a lot of things we can think about, starting from the very socioeconomic background, the poverty, maybe the population, and also the poor diet from your childhood. The bone mass gets increased only at the age of 20. If you are a poor eater or were not well nourished in your childhood, or you don't involve yourself in sports and games, probably you cannot increase the bone mass. And probably that part we need to look at. As a child, children must be well educated, proper diet, good healthy diet, exercises, and increase the bone mass so that this osteoporosis doesn't come at a very early age. So that is very important in prevention. So the diet plays a major role, and maybe the poor diet is one of the causes which I feel in Indian population, it may be very high. The third thing which I feel is maybe the sedentary lifestyle. I mean, I think most of us not very keen to do exercise. I mean, we are happy eating well and also, spending our time in front of TV or movies, but not putting ourselves to any exercise or any activities or sport or game. We have been bred that way from the beginning. Probably that is one thing which the lifestyle should change to increase the bone mass. I think that is very important. And probably I don't know what others think. I know this, the lifestyle, the poverty and the poor diet is the main reason why, what I think we have increased osteoporosis in our population. Dr. Sandeep, probably you can enlighten us more. What are the other factors which you think why we are, our population have an increased risk of osteoporosis?
Yeah, like I said, that lack of knowledge about osteoporosis in the rural population, high number of pregnancies in the rural population. And like we all discussed, that most of the doctors, or especially orthopedic surgeons, are focused towards treating their fracture and not focused towards preventing further fractures. So these are the factors why I think the Indian population is more prone to developing osteoporosis, or rather having untreated osteoporosis.
Dr. Prani?
Yes, my approach is almost same, but what I do, I every fortnightly select those patients from my OPD, and I offer them density scan, but that is ultrasound beds. It is not that popular, it is not believable, but the patients accumulated with that something fancy thing that they are going to be checked by some machine. And such 70 to 100 patients I check every fortnightly for a bone density. And then those who are found having a significant density, low density, then I subject them for further investigations and treatment. So,
Okay,
it starts with counseling, I think. It should start with counseling.
Yeah. So I think we are going to the next part of how to investigate. Probably that is the part you were discussing. And what are the negative effects of osteoporosis? I mean, we know the osteoporosis can present in many manners. We are, as an orthopedic surgeon, we are all aware of the fragility fracture. But other than that, like patients who have extreme back pain or general tiredness or some sort of debility. So what exactly you look for when you suspect osteoporosis, other than leaving the fractures in your practice? When you feel this patient may have osteoporosis or osteopenia or sarcopenia, as Ram was mentioning. Well, the negative effects, I mean, the problem with the osteoporosis, we know the loss of height, what he was mentioning, and the kyphosis, or getting up from the bed is difficult. They have a general weakness per se, and body pain, back pain. So do you look at these patients to find out whether they have osteoporosis as one of the causes in your practice? Dr. Prani?
So the loss of working hours is the major presentation. I think it is second in the list in the disability. So firstly comes arthritis, and next is the osteoporosis causing backache and all those things.
Okay.
So that is one thing, and osteoporotic fractures that can even disturb the family economy as well. Repeat fracture is again nightmare for the orthopedician to treat.
Yeah, correct.
So that way, prevention is the best key. That's what I feel.
Yeah, very, very well said. Yes, obviously, we don't want any patients coming with another fracture. So how do you investigate? I mean, normally when you feel the patient is osteoporotic, do you always send them for DEXA, or you do any other special investigations of your choice?
DEXA is a bit expensive. That's why we go with that ultrasound and hematological investigations first. And those having very high risk, were very low BMD, less than minus 2.5, then we subject them for DEXA.
I know Ram mentioned about the FRAX score. there are a lot of scores available nowadays for the
Yeah.
fracture risk assessment. But honestly, I should say that only in the books I have read, but in clinical practice, very difficult to see the risk assessment. The fracture risk assessment is more, I feel, like theoretical or maybe a research tool rather than putting into practice. But I'm not sure, anybody really practices the risk assessment score. Ram, what is your take on that?
Well, you're right. Those people who document, those people who publish, those people who print, they are the ones who are practicing it, or those who are seeing large numbers and are treating them non-surgically. So if you have like a fracture liaison surface or an FLS attached to your institution, yes, those are the people who will use the frac score. But otherwise, you're right. Although it's very simple, it's on your mobile, it's available for free. But if you don't have large numbers, I don't think it makes much sense. You need a team approach to do it. But even if you don't have that, you can go very simplistically. I mean, I'm very clear. I get a lady with non-specific low back pain. I do, as I said, the blood test, vitamin D3, B12, HbA1c, uric acid to look for the basic causes. I do an RA factor and anti-CCP to rule out any other cause of polyarthralgia. I do a serum creat, serum PTH, and I do a DEXA. If they are very elderly, I add a serum protein electrophoresis for M-band. Now, having done that, besides the imaging, the X-rays, we have the patient in front of us. The X-ray may show an old osteoporotic or a recent normal-looking bone with a suspicion. But first step is to correct the depletion of vitamin D. So you first replete the patient with D and calcium. Then get into your DEXA and decide whether you're going for A, B, or C. There are 3 verticals, as I said. There's a bisphosphonate vertical, there's a denosumab vertical, and there's a teriparatide vertical in our country. So this is the way that I go about it, and I'm pretty comfortable as I look at my patients, whether they're non-specific back pain or they're patients who need surgery, or whether they're patients who are being worked up for an elective surgery few months down the line. All are treated the same.
Right. So my question here is the DEXA is necessary for treatment?
If you're asking me, it's a routine in my setup. And between you and me, I see on an average about 60 patients with back pain in a week. And out of 60, I get about 15 to 20 DEXAs done.
Okay. So without DEXA, can we treat osteoporosis?
Well, you can. I'm not denying that. But then if you want to be a little bit more evidence-based and you want to be a little bit more planned as to which of the 3 verticals you want to use and how long you want to use it, somewhere you have to have some evidence.
Right. I think the point is very clear that if there is a fragility fracture, yes, you don't need a DEXA to prove that the patient has got osteoporosis. You can straight away start the treatment. And obviously, any postmenopausal females with any risk factors like rheumatoids or any previous fractures or any hormonal treatment and any sort of disturbance in the bone formation or like liver disease or renal diseases, possibly, yes, I mean, you should always treat the osteoporosis. It's not really necessary that you should have a DEXA, but DEXA is definitely is a tool to prove and is a gold standard to say that the patient has got osteoporosis. But I'm telling you that patients in the rural population where this scan is not available, you can take other measures, the risk factors assessment, like the age, sex, and the other secondary causes. All these you look into, and then in total you treat the patient rather than saying that you don't have a DEXA, so you don't treat osteoporosis. That is wrong. Probably that is a way you look at the patient as a whole, not as only one part. So coming to,
I'd like to ask Dr. Rex, if you allow me to add one point. So as far as diagnosis is concerned, as Dr. Ram very rightfully said that if you have to quantify osteoporosis, then BMD is the answer. And by quantifying, we decide which modality or treatment are we going to go for. So that's absolutely right. But we have to choose which patient we send for DEXA, because not all patients are able to afford it, and it is not available at all centers, especially our rural population. So when I was working in Gangaram Hospital way back in the early 90s, then Dr. Mani used to use an index called the Singh's index, which was a plain X-ray of the pelvis. But of course, it was subject to the exposure. If it was overexposed, then it appears more osteoporotic. If it is underexposed, it appears less osteoporotic. But using that simple X-ray, using the Singh's index, by looking at the thickness of the cortices, by looking at the trabecular pattern in the trochanteric region, you could have a fair assessment about the amount of osteoporosis. And then you could pick and choose. If suppose you find that on the Singh's index, you find that the osteoporosis is fairly high, then you can make the patient, you convince the patient to go in for a DEXA. Otherwise, if you find that the osteoporosis index is not very high on Singh's index, perhaps you can omit and save that much money for the patient and keep the patient just on calcium and vitamin D. That's the way how I do it.
Correct. Yeah, I think you're right. I mean, when it comes to treatment part, I think that's the next question. How are we going to approach the patient, the treatment? So coming to the awareness, how can we spread this message to the community? I think that is the key thing which very important in prevention, and also because the gravity of problem, as we mentioned earlier, by 2050, there is predicting more than 300% of fragility fractures and hip fractures. So it's a big problem for our community. And spreading awareness in the community, there are different ways our association is doing all the programs, and also leaflets and medias, or through the internet. We are communicating, telling all the groups. But even then, I still feel that it would hardly reach 5 to 10%. That's the max. So there must be some way to get awareness among all. One of the easy ways, which I feel, I may be wrong, that in the movies, like how they say that tobacco chewing is bad before they start the movie, our association should take a next step to tell our central government to say what is osteoporosis, and if you get a fracture, and what are the problems you face, and how to prevent this fracture and treat this osteoporosis from the beginning. So if you can send a message, or some sort of advert through celebrities in the films or in the TV, probably that is the best way that will reach nook and corner of India, so that everybody are aware, or will come to know at least what is osteoporosis is. So I think probably you can tell what else to add more to spread the awareness.
I think apart from awareness, there is, the biggest thing which I have seen in my side of the country is that people have, they are scared of using calcium for very long periods. So that also needs to be taken away from their minds. The people say that they think that having calcium, regular dose of calcium will lead to kidney stones, it will lead to gallbladder stones, of all the things. At times it becomes very difficult to convince them that these gallbladder stones are not because of calcium. Calcium stones are not formed, kidney stones are not because of excess intake of calcium. So that's also a very important part of increasing the awareness in the community.
Okay. Dr. Indranil Dutta, is he here?
No,
what is your opinion?
I think he's there, but he can't speak. He's busy attending surgery. Yeah.
Okay, Dr. Prani.
I'm with some social groups. I am arranging these osteoporosis detection camps every fortnightly.
Yeah.
The patients having same symptoms or similar symptoms, if they gather together, then it is very easy to explain them, counsel them together, and then we offer that ultrasound-based scanning as a tool. Though it is not a very accurate thing, but it is just to gather those patients together, counsel them, and that way we can deal with those.
Correct. Yes. So I think, we should find the ways to spread the message in the community, so that osteoporosis is a deadly disease. It's a silent epidemic, silent killer, and one must be aware of this problem, so that you don't end up with the osteoporotic fracture. That is very important. So coming to the treatment, I think Ram has put it in a nutshell. The three verticals, I think, is put it very nicely. The different ways of looking how to treat, which patient treat, whom doesn't need treatment. What I feel is you need to classify your patients as a low risk, high risk, and very high risk groups. Probably that is the way I look at it. Patient low risk groups, there where there is no given risk factor or any sort of fractures or less postmenopausal females, but not with any serious diseases or medical illness. They come for a consultation, and probably I will just put them on calcium, vitamin D, teach them about the diets, the dietary supplements, and insist on the exercises, the core strengthening, and all those things to improve the bone mass. Probably that is the best way. And the patient with a high risk, obviously, if they have a positive DEXA and with a fracture or a secondary cause of osteoporosis, or you could identify risk factor like rheumatoid, and those sort of patients, yes, we must treat them energetically. And these patients may need a pharmacological method of management. So it is again your choice depending on the patient's conditions, the pros and cons, the side effects, and you decide whether you go for the oral bisphosphonates or intravenous zoledronic acid, or you think about the denosumab, or the patients who have a very high risk patients. That's my third group, who have multiple fragility fractures, or you've been treated with anti-resorptive drugs. Again, the patient has got another fracture in the vertebra, or patient coming with extreme severe body pain, loss of height, and we can see the bone is really thinned out, something like a frame like vertebra, and where the patient is so fragile. Probably those patients treat them very energetically with the bone forming drug like teriparatide, and again I combine with anti-resorptives as well, in addition to the calcium and vitamin D supplements. So that is my approach on treating the three different groups. Probably everybody has got their own protocol of how to approach these patients. Probably you can also tell, how you do in your practice, Dr. Sandeep, how you treat your patients or group them.
As far as you're right, number one, we need to group them, or we need to quantify the osteoporosis. Yes. Apart from the actual medical management of osteoporosis, we need to ensure a few things: that there is adequate protein in their diet, there is adequate calcium and vitamin D in their diet, and there is adequate weight-bearing exercise, which is also a very important part of treating osteoporosis. You just can't treat osteoporosis in a non-ambulatory patient. Now, as far as choosing between the three verticals, as Dr. Ram has discussed, we know that our primary aim should be to increase the osteoblastic activity. And secondary aim is also to decrease the osteoclastic activity. We know that bisphosphonates and denosumab decreases the osteoclastic activity, whereas it is only teriparatide which increases the osteoblastic activity. So from my knowledge, from whatever I have read, we should ideally not put the patient on denosumab primarily. They should be first either put on calcium with teriparatide for a period of 2 years, and then you can put them off denosumab 6 monthly, or oral bisphosphonates. There is a third group whereas the DEXA scores are very low, 4, 4.5, -5. In those patients, perhaps we can do a simultaneous denosumab along with teriparatide therapy. And that is the way I have read it, and that's what I have been practicing. Perhaps Dr. Ram would be able to give better light on that.
I am in total agreement with both Dr. Rex and Dr. Garg. As I look at it, there is monotherapy, there is sequential therapy, and there is combined therapy. Most of our patients, I'm looking at the majority, will be encouraged to have monotherapy. If they are relatively young, when I mean relatively young, let's talk of women who are immediately post-menopausal. Okay, so they're relatively young, 50 to 60 age group, treatment naive, and they have DEXAs in the range of -2 to -3. Why am I saying -2 to -3? Because I sort of, if they are diabetic, if they're rheumatoid, I even start pharmacotherapeutic treatment at -2 DEXA, T-score being the lowest. In that situation, I am not unhappy initiating them after replenishing them with calcium and D3. And I mention that every time. You cannot give anti-osteoporotic in a calcium deplete or a vitamin D deplete patient. You may do more harm than good. In those patients, I would initiate them initially even with a bisphosphonate for a period of time where they don't really have fractures, where they have non-specific back pain. And I talk back pain because I see many of them. And I buy them time. Why do I buy them time? So please understand, we can give bisphosphonates for 8 out of 10 years maximum. From what we've learned, we can give it for 4 years, then treatment holiday, then 4 years, then treatment holiday. So it's 8 out of 10 years we can give bisphosphonates. We can give teriparatide 2 years. That makes it 10 plus 2, 12. And we can give 10 years maximum denosumab as of today, 22 years. My mother is 50 years post-menopause. So please understand, there are going to be women who are going to be living that long. So we got to use our drugs very, very sparingly and not overuse a drug. So I totally agree with what Dr. Garg said, that if they're really bad, then push them, use the atom bomb first, which is your teriparatide. However, if they're not too bad, then use the other modalities first, maintain them, buy time, and then get your teriparatide in. Because till the time that we have abaloparatide or omosuzumab, this is the only anabolic we have. And although today in India, we are not allowed more than 2 years, it's going to be very soon that we are going to be allowed to use more than 2 years of teriparatide, and it will be our decision. That means it's going to be the clinician's decision thereafter. So there's going to be more responsibility on us if we restart teriparatide for another 2 years. But these are things which are not yet on label in India. So we have to go a little bit slow with that. So where I come from is I am still using bisphosphonates. Many people have thrown it out. I don't. I still have it. I use denosumab, especially where I have a high risk for cancer in the past or any history which is not clear, or if I have renal challenged patients or I have a PTH which is very high, I do initiate with even denosumab in a treatment naive patient. But yes, worst situation I'm using combined, which is I'm using denosumab plus teriparatide for the first 2 years. These are those real bad patients, and they turn around remarkably. So that's where I am, and I believe that you have to mix and match, and there's no one size fits all. That's how it is.
Yeah, I think the consensus is same. I think everybody are saying the same, that we start with calcium, phosphorus, and vitamin D, and then bisphosphonates majority of times, and then select the denosumab as and when necessary, and then add up the bone forming drug like teriparatide in a severe situation. So probably that is what we are mentioning. I think we are right that this is the way that we all treat our patients, and but sometimes exemptions are there, as Ram was mentioning, that patients with carcinogenesis, you cannot give teriparatide, and you need to think about the other alternatives. A patient with renal failure, you can't give the bisphosphonates. So in those cases, you used to use denosumab. And where you want a quicker action, quick anti-resorptives, probably denosumab has got a role. But you need to understand that is a rebound resorption as well if you start the denosumab and then without dealing with another anti-resorptives. So that is also, you need to know the plus and minus of each drug and value it accordingly and play accordingly. And with the bisphosphonates being a good drug, but only problem with the biggest orthopedic challenge what we face is the compliance. That part we have forgotten. We all talk where tell about 2 years, 3 years, 5 years, 10 years, but how many patients will be really compliant or will take the drug as you prescribe? If you take calcium and vitamin D, for example, though we tell them for take 6 months or 1 year, I'm not sure whether they take 6 months or 1 year continuously. They take for 2 months, 3 months, then they say, okay, I'm fine, I will stop. And they don't come to the doctor, or you give an appointment after 6 months of denosumab for a repeat dose. How many of them really turn up? So that is again a biggest orthopedic challenge, and we need to have some sort of registry to trace them or track them and then make sure they get treatment. So for this, awareness matters a lot. I think that is my opinion, because I'm sure the fallouts will be definitely 30 to 40%. Definitely, you cannot get 100% getting the patient treated throughout for 7 to 10 years down the line. And I'm sure everybody will agree on that. What do you think, Ram, on this? Because my patients are different from what you see. They're not very educated.
Compliance and adherence are totally dependent on how much time you have individually counseled them at the initiation of treatment.
Yeah.
And I strongly stand by that. And you have to put in that extra 10 to 20 minutes the first time. Once you do that, sir, they will adhere to your treatment. You have to tell them how important it is. You give them that time and they will respond. So we have to look within. We don't have to look outside, sir. It's like my teacher who told me that if you don't understand, it's my fault. So it's very clear. If my patient is not compliant or is not adhering to treatment, it's my fault. We have to want to accept that.
That is true in the acute scenario, but once they feel they're fine, they're good, they don't stick on to the regime. That is the problem.
So they do.
I see. Okay. So I think we have come to the end of this session, and we had a wonderful discussion with all the senior colleagues, and they come out with different solutions and the problems what we are facing and how to deal with this, the ways to spread the message to the community, and what are the ways to how you investigate them and how to treat these patients. And I'm sure you have a clear-cut idea at the end of this discussion how we are going to treat our patients in future. So this problem, it's not only in our hands, it's the whole community, everyone other than the orthopedic surgeon, the whole doctor community should treat this osteoporosis in a big way. And I thank the Emcure for giving me this opportunity to chat this session, and thank you one and all. Thank you.
Thank you, Dr. Rex. Thank you, Dr. Ram, Dr. Prani, and thank you, Dr. Ketan.
Thank you, sir. Thank you. I wish here to thank all the faculty for bringing excellent clinical pearls and bringing out a lot of insights and lot of protocols for diagnosis and management of osteoporosis. So definitely, sir, education remains one of the important things. Educate about osteoporosis, sedentary lifestyle. We have to be more active, and definitely knowledge of osteoporosis among the community will help to tackle this problem. So the next, sir, what we have done is that Emcure side, to increase the awareness about osteoporosis, about the general public, we are introducing a website on osteoporosis. That website is osteoporosis.com. So this is the general outline of the website. So we have got information on what is osteoporosis, how it is diagnosed, prevention and management, women and osteoporosis, some frequently asked questions. So here we have information about what is osteoporosis, information of all about bones, types of osteoporosis, what is the incidence, what are the risk factors, diagnosis, tools, prevention and management, which includes the nutrition, exercises, and treatment part. We have a special section on women and osteoporosis, few Indian statistics and frequently asked questions. So this is the website which is there, and this website is now live. So anyone can log in to this website. So you'll get all the information on the website. So what I'm doing is I'll just share a live website. So this is the website which is there. So it has what is osteoporosis, diagnosis, prevention, management, women and osteoporosis, some frequently asked questions, and so on. So we also have the different statistics which are there on osteoporosis. So this is a specially designed. This is a specially designed website on osteoporosis. So I hope the more awareness on osteoporosis we all can increase, definitely we can tackle this problem in India. So
that's a very nice initiative, Dr. Ketan. And I think our patients are also going to appreciate. So from my side, there is a request as our industry partner, if you can arrange to have some kind of posters regarding this website, which we can put up in a clinic for our patients to browse. And secondly, if at all we can at some stage develop a vernacular version of this in different languages. So.
Okay. Yes, sir. Thanks, sir. It's really it will be helpful. Yeah. Yes, sir. So that's the website. So that is www.osteoporosisinwomen.com. Okay. So from my side, sir, now we have come towards the end of the excellent webinar we had today. Great insights from all the faculty. So from Emcure side, I wish to thank Dr. Chadda sir, Dr. Rex, Dr. Sandeep Garg sir, Dr. Prani, and also Indranil Dutta for sharing their very valuable insights and bringing a lot of clinical pearls today. So I wish you all a happy World Osteoporosis Day, and also all of you a very happy Diwali and a prosperous New Year. Diwali is on the anvil.
Happy Diwali to everyone.
Happy Diwali to all of you.
Thank you. Happy Diwali to all.
Yes, sir.
Thank you, Ram. Thank you, God. Thank you, Ram. Thank you,
Thank you,
Kulkarni.
sir.
Thank you, Ram sir, Rex sir, Bhaskar sir, and Sandeep Garg sir.
Thanks.
Thank you so much, sir.
Thank you. Thank you, Ananda.
Thank you, everybody.
Thank you. Thank you so much. OrthoTV can stop live.
Rishi, please stop the streaming.
Thank you. Thank
Rishi,
you.
can you please respond?
Ready, sir. Thank you, sir. Thank you so much.
Thank you so much, sir. Rishi, can you please stop streaming, or can you please respond? Ketan sir, can we end?
Yes, yes.
If we leave the meeting, automatically it will get end.
Yeah.
Okay. Thank you, sir.
Thank you. Okay, then I leave.